Okay, thank you so much, Diane. Good to see you back. We're 3/4 of the way through the day, so I hope you got a nice jolt. And before we go on to our next panel, if you see me carrying this microphone, it means I'm going to put you on the spot. So I'm just curious to hear from some of you what your favorite moment so far has been. So I'm just going to start picking on people. Hi there. No, don't look at your phone.
That's right.
What was your favorite moment so far?
I found the discussion quite interesting with Labib, notably because she's new in the position, coming from national politics, so like seeing her like transitioning into preparedness. And also quite a bit has been done on strategies. Now time to see like action with like acts. So yeah, found it quite interesting.
Okay, well, I'm glad I pinned you down because that was a good answer. Thank you so much. Let's see. Can I ask you what the most remarkable or favorite moment was so far for you?
I have seen a lot of interesting things. I'm only a little bit pointing out. I would like to point out an opportunity that not has been mentioned so far. So concerning pharmacies, we talk a lot about doctors and nurses, but I think pharmacies can play a big role in easy and accessible medicines, and that it's also very lowly accessible for people. They walk in all the time, and the pharmacies have a lot of knowledge. They can be a very easy access point for medicines if we have like small hubs of stocks there. And maybe we can be also more helpful, like points of cares that's not been mentioned yet.
Okay, so some constructive criticism. Anything that you did, and any good points that we?
No, there were a lot of good points, but I didn't hear that, and I would like to have that.
All right, anybody, you sir, anything stood out to you today, or something you're going to be thinking about later?
The first discussion about regulation, I think there's a lot that we need to go a little bit deeper, because this issue of regulation is brought many times with this idea that if there is no regulation, we are going to be happy and have the wonderful drugs in the world. And this is simply not true. History tells us that we need regulation and we need to enforce it. And then industry has to cope with that. And that's it. So I did. And there was a piece about increasing the fees so that the authorities or the general authorities could have more people. That I found particularly intriguing, because that, of course, coming from a big multinational, that's very good for them, because they can support 1 million for a drug. But for a small or a startup, that's going to be a little bit tougher.
Okay, indeed. So the whole regulation versus innovation conundrum versus safety. There's a lot of debate about how much we can have it all. All right, I'm gonna sneak back up onto the stage here now. Thank you so much to those of you who participated in our little interactive session there. So yeah, I think what we heard from everybody is the challenge of dealing with all these complex issues, and nothing really is more complex than what we're going to tackle now. Chronic diseases, cardiovascular disease, diabetes, cancer, they account for 90% of deaths, yet they remain one of the hardest things to tackle, in part because of the political challenge, and just like they're all, I mean, I just named some categories, but we all know that within each of those categories, there are a gazillion different subcategories and causes. European Commissioner Verhey says that this is a priority, and the European Cardiovascular Plan is expected on the 16th of December. So the next session will untangle what's at stake here. Do we need a cure, prevention, or both? Rory O'Neill will be with you in a minute with the panelists, so give them a warm welcome as they come to the stage.
Hello again, everyone. My name's Rory O'Neill, a healthcare reporter at Politico. And for the next half an hour or so, we're going to be talking about chronic or non-communicable diseases. So these are the world's top killers, plaguing societies, costing millions of lives and draining economies. In 2021, they caused 75% of non-pandemic deaths. And in the WHO Europe region, they cost around 500 billion a year in lost productivity, according to estimates. So what is to be done about this devastating health crisis? To help me answer that, I've got a top panel of speakers alongside me. We have MEP Stina Boss, Vice Chair of the SANT Committee from the Renew Group. We have Stefan Schreck, Advisor for Stakeholder Relations at DG Sante in the European Commission. We have Gordon Galea, Honorary Professor at the University of Malta and a former Strategic Advisor on NCDs and Innovation at WHO Europe. And finally, we have Alex Di Giorgio, Senior Vice President for Biopharmaceuticals and Medical at AstraZeneca. Thank you all very much for joining me. So I'm going to start with the EU Cardiovascular Health Plan. And the reason for that is we've seen the draft that we published on Friday. For those of you that haven't seen it, don't worry, I will tell you exactly what it says. I think the best place to start would be the Commission's plan to introduce new levies on food that is highly processed, is high in fat, high in sugar and salt, or alcopops as well in 2026. So we don't know yet exactly how high the tax is going to be or how those terms will be defined, but that's what the Commission wants to do according to the draft. Stina, this is an area you follow closely. What do you think of what the Commission is thinking here?
Well, first of all, I don't really want to comment on something that leaked, but I want to say that dealing with this, and you named the figures, of course it is obvious that we have to think about prevention. If you take the figures we know today and you know the demographics and we don't do anything, it will financially and of course also talking about lives and life quality be devastating. So we have to do something. And prevention must be at the forefront of the initiatives that we want to see. And I also hope that we will see some tough initiatives on the fact that the choices we make have to be our choices. So a lot of empowerment and information, but also, and I don't know whether it will go this far, but I would also like to see that the financial tools, namely taxes, would be introduced to help us prevent and guide people in the way that they consume.
Thank you. Gordon, can I get your reaction to what's been reported?
I will echo what Stina said, because clearly we don't have the released document yet, and we should not be commenting on leaked documents, but I'll set the cardiovascular action plan against a standard that people can then compare. WHO has a set of best buys, and in March of this year we published what we call the quick buys, cost-effective interventions that can make a difference in population health within a period of 5 years. So there are 25 interventions, many of them related to cardiovascular disease, that can have a quick impact and cost effectively with a good return on investment. Yes, there is a mix of behavioral and structural interventions. So it's not just making people aware of their risks, but changing the system. Fiscal interventions achieve two important outcomes. One, they generate revenue. Secondly, they provide industry with a standard. So if a food above this threshold of fat, sugar, and salt is going to be taxed, industry has an incentive to lower that threshold. So tax is not to be seen as an aggressive intervention, but a guidance intervention as well. And so I think those are the best buys. Many of these interventions are in the best buys and in the quick buys. And I would encourage people in the audience, in person or online, to have a look and to read all the documents together.
Alex, can I get your reaction to the
Well, I don't think I can speak to anyone near the level of authority as Stina and Gordon, but I think, just to echo what Stina said, I think prevention has to be a priority. I would say those sorts of initiatives will obviously pay dividends in the long term, but equally there do need to be shorter and medium term priorities around how to identify the highest risk patients that have the greatest impact on health systems today. And we need to start that now, making sure that we're getting them access to guideline-directed medical therapy that can prevent disease progression and keep people out of hospital. That's how you help health systems to become more resilient. So it needs to be a bit of both. It can't just be, prevention alone.
I'll come back to you in a second, Stina, but I just wanted to ask Stefan, now obviously, very grateful that you've joined us here from the Commission. So I appreciate, there's only so much you're going to be able to say about the plan, which has not been officially published yet. But are you able to tell us any more about how the Commission is thinking on cardiovascular disease, on prevention in particular, and the kind of work that's gone into the document that's been circulating?
Yes, I can. And first of all, I would like to say that the Commission is still thinking. You mentioned the 16th of December as potential date of publication of that plan. And in any case, it is true that there needs to be a focus on prevention. That is really absolutely essential, because a case avoided is really the best outcome. But we have the idea of addressing the whole continuum. So apart from prevention, also early detection and screening, and therapy and management, and also rehabilitation. So the whole continuum of cardiovascular diseases. Now, it is clear that also the food and drink industry will have a role, and while I can't comment on anything now at this stage, I would just like to point out that there are several ideas already around. For example, a code of conduct of responsible food, business and marketing. And we are also supporting member states that launch reformulation exercises that have as an aim indeed to reduce saturated fat and salt and sugar in food. And then I would also like to mention the initiative on public procurement of healthy food, because there's a lot of public procurement. You think about public administrations and schools and prisons and the military. And if that would all be healthy food, that would have two positive effects. On the one hand, of course, it would be healthy for those eating it, but it would also create demand for healthy food in the market. So a lot can be done also beyond any discussion on taxation. And one thing I also would like to mention briefly is we'll of course learn from what we did with the cancer plan. So this will be something which will involve all the stakeholders, essentially. We have had a consultation where everybody could make submissions. We had 2 webinars on that, where basically civil society organizations could tell us what they think. Very important is also to have the member states, the ministries of health on board. And for that, we had also 2 discussions already in the run-up to the development of the plan. Because, the particular situation the EU is in the area of public health, which is just to complement what member states are doing. It's the member states which are responsible for their health system, requires that we need to motivate member states to do something useful, and for that they need to be on board right from the start. They will also be on board when it comes to financing of projects to implement the cardiovascular plan, because obviously most of them will be funded from EU for Health, and that means there's a so-called comitology procedure, so member states have a direct say in where the money is flowing. So they are on board really in all the phases. And that is something which we learned also from the cancer plan, from the implementation.
Stina, did you want to come back?
No, I just wanted to, actually I started by thinking about the early detection and the screening plans, because I think they are very, very important also. But also I want to say one of my favorite areas is knowledge sharing, simple as that. Share data, get more knowledgeable together, understand the reasons why, and so on. So all these areas, we've got the health data space there. Use this much more to get knowledge surfaced.
Yeah, Stefan.
Yes, that is indeed what Sine said is very important, and we are making a special effort which we call sharing of best practices. We have established a whole system where people can submit practices, what is done in regions or member states, mainly on prevention. This is then analyzed by experts on the validity so that our criteria are met, that this is really can be called a best practice. Then it is presented to member states. And then many of the projects which are funded in the different areas these days are based on the idea to take things which work already in some member states to also implement them in other member states. And that combines several advantages. We know that it works, yeah, which is much better than any sort of theoretical concept. Member states, governments and authorities feel much more comfortable with implementing something which was already done in a fellow member state than something which is assembled by some bureaucrats in Brussels or some experts. They feel more comfortable in their peer group among other member states. And I would also like to mention the aim of that project is then to change the approach permanently in a member state. So this does not need permanent funding, but can rather be done in a one-off exercise, which is very important for EU projects because we have the financial regulation and it's very difficult to secure funding in several phases, one after the other.
Yeah, sticking with UPFs for a moment, Gordon, the food and drink industry and its communications on this issue tend to highlight that lots of dietary authorities have so far declined to take a firm stance on guidance around UPFs. Several reasons for this. One of the main ones is they say it's not really clear to what extent ultra-processed foods are unhealthy in and of themselves, or if they simply tend to be, for example, energy-dense, highly palatable, high in salt, saturated fat, the same risk factors that we've known about for a long time. Can you tell us, what does the evidence say on this, and is there an emerging consensus around the UPFs?
There's still discussion on what UPFs are specifically, but clearly they are a set of foods that contain a high proportion of unhealthy nutrients. Now, that has multiple evidence on the immediacy of the effect, the dose response, the duration of the effect. Time in our commercial determinants report last year in June, launched during the presidency of the EU by Belgium, we named them as one of the 4 factors that are causing over 7,000 deaths a day in Europe. So I think it's a bit of quibbling to be focusing on this label, and it's better for the food industry to really grab the bull by the horns and realize that, okay, for a long time, they have been in a position where they could get the 3 cheapest ingredients, fat, sugar, and salt, package them in a highly addictive form with mouthfeel and other effects that make them immediately pleasant with addictive properties, and stop and sell them at profit margins that are extraordinary, very cheap ingredients and high profit margins, and then claim that they are feeding Europe or feeding the world. This is not feeding, this is actually addicting. I think the food industry should not be condemned by far. There's a large part of it that is concerned with the delivery and supply chain of healthy fruits and vegetables, of making sure that people have the produce available in cities where it's no longer possible to grow your own. So there is a strong dependency on healthy food. And there is a lot of space for partnering, but both the packaging and the digital and other forms of marketing, and often the targeting of children with these foods, need really to be exposed, and the industry itself to step back from these practices.
Yeah, just one more question on this, and then we'll move on, because there's lots more in the plan besides taxes. But Stina, I thought you might have a view on this. I mean, the food and drink lobby have taken the news about as well as could be predicted, I suppose. They're calling the plans the death of science-based policy, and the moment that the Make America Healthy Again movement comes to Europe.
Yeah.
Is this where, are you preparing for, is this where the discourse on this plan is going to go? And what do you think of that narrative? Because, I mean, you sit in the SAN committee, you'll have seen that Make America Healthy Again narrative, that is present in Brussels at the moment. But I'm curious to see whether you think the cardiovascular plan lines up with that.
But look, I mean, for me, it has to start with being a little bit of a joke. And I can really connect to the fact that the US wants their population to become healthier, and they want a stronger healthcare system. That's their obligation. We are more healthy, as is, in Europe. And we have a better combined healthcare systems amongst us. And we should look after our citizens. And looking after our citizens is making sure I'm a liberal. I mean, I believe in free choices, but you do not give your citizens free choices if you are fed with something that is not nutritious and it's sold as if it's food, and you don't have any guidance, you don't have any education. Then you need strong politicians and you need strong gateways to make sure that this cannot happen. And I really echo, now I can do it the other way, we need to be friends with the food industry, obviously. But they also need to understand that we ask them to make food, not something that actually destroys people's lives. We want them to make food. And then we will have, and this is going to be a very big and difficult debate, I can see where the things are coming from, but then we will have to explain to our citizens that this must come at a price. But if you look at what you pay per gram of nutrition, you're much better off buying a piece of fruit or a well-prepared bread than something that you buy just quickly on the corner because it's easy and it's cheap and with no nutrition in it. So we will have to also have that conversation with citizens. And for me, that goes on the EU level and, of course, also on the national level.
Alex, can I bring you in here? Because, yeah, as I was saying, we don't want to just focus on taxes. There's an awful lot more to cardiovascular prevention, treatment, and indeed for chronic diseases in general than that. I mean, this plan is, I suppose, the spiritual successor to the EU Beating Cancer Plan, one of the biggest files of last mandate. What lessons would you advise the Commission to draw from that plan, and what do you think the priorities ought to be that you'd like to see them focusing on?
Well, I think a lot of the principles, and again, notwithstanding the fact that it's a draft, a lot of the principles in the plan as we saw it are very consistent with the cancer plan around prevention, early detection and screening and treatment and care. So I think those principles are really good. So the what, I should say, is really good. I think where it's light and where it'd be good to talk more is the how do you actually do it. So, taking that piece around early screening and detection, I think to expect primary care to do it is probably unrealistic, given how much primary care has to deal with today. So, I think we do need to think differently about how do we screen all of these, the spectrum of cardiorenal and metabolic diseases that we talked about, type 2 diabetes, hypertension, chronic kidney disease, obesity. How do we screen these patients in the community? How do we leverage pharmacies and diagnostic hubs and mobile units and really think differently about how do we create an integrated, community-based network that can use simple, affordable diagnostics that can be done by anyone? That's the first thing. I think that's a major challenge that we need to think about, and every health system in every member state needs to think about that. I think the second thing, in terms of the immediate impact, as I said earlier, is around how do we identify those high-risk patients who are already having the biggest impact on health systems. How do we identify them using standardized electronic medical records? How do we pull them in for review? How do we optimize them on guideline-directed medical therapy that prevents disease progression and keeps people out of hospital? We've done a lot of work in partnership with health systems all over the world. We have something like 200 partnerships in more than 50 countries. And looking at different ways that we can do that, where we're providing sort of multidisciplinary teams, for example, that are doing virtual assessments of patients and making a holistic recommendation rather than treating individual diseases, that's in part why things get missed and why patients fall through the cracks. How do you create multidisciplinary teams that are managing all of the patient's risk and optimally treating all of those conditions as one? There's lovely examples all over Europe. There's a fantastic one recently from Canada called the Best Care Program, which was really designed at optimizing lung health for patients with COPD and for lung cancer. And for a very small investment, I think it was about $2 million, they were able to identify and optimally treat 25,000 COPD patients. And in a 2-year period, they reduced hospitalizations by 72%. They reduced cardiovascular events by 61%. And they saved the health system about $30 million. So, instant savings that can be generated very quickly that could then be reinvested in other community-based practices. And so I think the third thing then is sort of policy with teeth, right? As it actually, rather than just top-down policy, how do we incentivize greater adoption of guideline-directed medical therapy? How do we reward the health systems that are doing it really well? So again, they can reinvest that money in community-based offerings that are going to have a material impact on the non-communicable disease burden.
Did you want to come in on that?
Yeah, I just wanted, because, figures always come in well in these discussions. And if you just say that we could halve the costs, we just take half of the costs, that's an enormous amount of money. And if we could get around to say, we do this together, we do this as EU, and we find a way where we can do early detection and screening, and we find a way to do it, with regions, and find a way. And look at this as investments rather than just costs. That would be the business case of this century. 100%. Because it's going to be so much money on the table after we've done the investments.
What about personalized treatments as well? That's something we understand as one exciting sort of line of inquiry that the Commission is thinking about. Alex, maybe you could start us off on what are the major obstacles to the development and rollout of personalized treatments that we need to be aware of, and how high is the ceiling for them to make a big difference here?
I think the biggest challenge at the minute is around having a really advanced diagnosis capability. So we're having to phenotype or genotype patients to really understand what is driving their disease. Let's treat what's there rather than treat what's not there. And so building centers of excellence that have the capability to do all sorts of multimodal diagnostics all under one roof, So you get a much more accurate picture of what is driving that patient's disease. You know, health systems all over Europe have access to innovative medicines that prevent disease progression, but obviously you need to understand what is the biological driver. And I think today health systems are quite fragmented. It's quite difficult to get a referral to a specialist that has access to those sorts of technologies. And again, we've done a lot of work, particularly in disease areas like amyloidosis, for example, helping to expand these centers of excellence to be able to diagnose and treat patients under one roof. I think that's a kind of a key driver moving forward if you want to make precision medicine something that everyone has access to.
Stefan, can I ask, how is the Commission thinking about inequalities in chronic diseases? I mean, what are the major inequalities that prevail among people suffering from chronic diseases, and how is the Commission thinking about how you can structure the plan to try and alleviate those?
That's obviously has ever been actually a very important objective of the Commission in its health policy goals, because we can see everywhere that several dimensions of non-equal access exist. Yeah, not least also the socio-economic status, for example. And it is also clear, if you think a bit about it, that if we make health policy that in the end benefits only part of the population, then we are doing something wrong. And I can't tell you exactly how it will be done for cardiovascular, but as an example, as part of the cancer plan, we have set up a cancer inequalities register to actually measure inequalities across all the part of the cancer continuum, from prevention to screening to therapy and rehabilitation, for all sorts of discrimination that you can have there. And that is a very innovative approach. And we hope that will help in the end, not only for cancer, but also for other diseases, to have a better evidence basis for decision makers to avoid creating inequalities. Because it's clear that if we identify a certain group which doesn't have full access in the area of cancer treatment, then it is rather likely that they will also have difficulties with access to treatment of cardiovascular diseases. So even if it's only on cancer, I think we will learn a lot also for cardiovascular and actually all other diseases. And so it will help a lot in policy making in the future. But let me repeat, it is really super important for policy making for the Commission.
Stina, you've been vocal on that issue. Now, you know I'd never ask you to comment on a draft, but I think the section on inequalities in there was about 2 paragraphs long. So, do you think what do you think it should say about addressing inequalities, and do you think there's anything that could be expanded on, and how much sort of funding needs to be put on the table to help understand, say, the gender-specific implications of cardiovascular disease? That's one topic of research.
Yeah, no, I do think that all the inequalities need to be addressed, be it in or out of the final plan. I would expect that it will be in. And the inequalities, especially tied to gender inequalities, actually, if you test this with people our age, if you allow me, they would say, "What are you talking about?" I mean, we have been so used to living through periods where gender equality was a no-brainer. It was just, this is how we see each other, this is how we live. And then, you suddenly realize when you deep dive into it that females are diagnosed with the same diseases 5 years later than men. How can it be? And I won't elaborate because you can get me going on this one bit, but it's really, really strange. So this has to be addressed, in my opinion. And it is like 50% of the populations are female. So it's not just a tiny little corner of things. But allow me also to have one comment on the personalized medicines, because it's my favorite subject. Rare diseases. Why do we have to work fast, soon, cross-border on rare diseases? It's because it's personalized medicines on speed. And that actually corresponds directly into, for example, rare cancers. And it gives us an opportunity, if we work together, we've got millions and millions of people that can actually provide the data. And this is where I think, this is where the European Union for citizens really makes sense.
And before we finish, Gordon, I just want to ask you, because I cover global health, and I was following over the summer the high-level meeting in September on NCDs, but over the summer the negotiations over the political declaration that came out of that, and we had, as is often the way with these things, we had an initial draft that started out quite ambitiously, would say targets to tax sugary drinks, tobacco, alcohol, and over successive drafts these were whittled away, civil society claiming the result of or what appeared to be intensive industry lobbying. Can I ask you to reflect on the outcome of that high-level meeting? Did it help generate some momentum in the fight against chronic diseases in the way that was hoped? And what did you think of the declaration?
The success of the UN high-level meeting comes out of some of the numbers. 140 countries registered to speak about it. 90 ministers of health came, 20 heads of state. And for the first time, there's a negotiated draft that contains smart targets on tobacco, on treatment of hypertension, and on access to mental health services. There was the unification of mental health, and with a much higher priority and space given to mental health than ever in the 4 UN high-level meetings. So that part is the success. I have to honestly speak about a certain disappointment with the way the arguments on structural factors, what we call the commercial determinants, which was diluted down to commercial factors. I do think that if we do not focus more on the structural factors, the environments and the systems in society that create non-communicable diseases, then we're going to have more inequality, and we're going to have a greater burden. So as often, I think the word is 6-7. There are strengths and weaknesses. And I think we've also learned the lesson that countries want increasingly to discuss trade and security in New York and technical issues of public health in Geneva. And maybe that is something to be taken forward as we discuss future UN high-level meetings.
Okay, that's a great note to finish on. We're going to have to end it there because we're out of time, but thank you very much to my panelists, and stay tuned, please, for my colleagues Gregorio and Guidra. Thank you so much.